Hello everyone, my name is Traci Achi. I am a Doctor of Nursing practice candidate with Maryville University. I have the honor to present my project implementing the ankle-brachial index screening in patients with diabetes mellitus. My committee members are Chair Dr. Linda Studley and Community Person Dr. Esther Kumar. There has been a worldwide increase in diabetes in the last decade. Diabetes mellitus is a chronic disease characterized by high blood glucose levels. When blood glucose is uncontrolled in a person with diabetes, they may experience microvascular and macrovascular changes over time. Peripheral artery disease, PAD, is a macrovascular complication caused by atherosclerosis, which is the accumulation of plaque in the artery in the lower extremities. The purpose of this project is to implement the ankle-brachial index screening in patients with diabetes. The ABI is a non-invasive, low-cost screening that measures the systolic pressure from the brachial arteries in both arms and both dorsalis pedis and posterior tibial arteries in the ankles using a vascular Doppler device and blood pressure cuff while the patient is lying in a supine position. The ABI is calculated by taking the highest systolic pressure of the dorsalis pedis and posterior tibial, dividing it by the highest systolic brachial artery pressure. These produce ranges that detect PAD. Prevention of major cardiac and major limb events is the primary concern. Intermittent claudication, IC, is a symptom of PAD, which occurs when blood flow to the muscles decreases due to obstruction or blockage of the arteries caused by atherosclerosis. IC may include weakness, numbness, coldness, diminished or no pulses, shiny skin in the lower extremities, and pain and cramping during physical activity that gets better at rest. Early screening can facilitate immediate intervention because some patients may not show signs of IC, making it imperative for routine screening of patients with diabetes in primary care. Patients with PAD are at an increased risk for major adverse cardiovascular events and major adverse limb events, such as heart attack, stroke, and non-traumatic amputations, which has resulted in a higher rate of morbidity and mortality. Therefore, screening for PAD in primary care is essential. There is a significance in nursing and healthcare in general regarding PAD assessment and management. Patients with PAD often present with signs and symptoms. Promptly identifying signs and symptoms of PAD in patients with diabetes mellitus is essential in nursing. There is a need for more primary care providers. Advanced practice nurses have established themselves as leaders in the healthcare industry and have taken an active leadership role in primary care and have established themselves as healthcare leaders. APNs have specialized skills to assess, diagnose, prescribe, implement, manage, and educate patients with various diseases. APNs can diagnose and manage patients with PAD, successfully train appropriate staff on performing ABI diagnostic screenings, or perform the screenings themselves and provide recommendations and interventions as necessary to prevent higher morbidity and mortality rates. There is also a significance in healthcare. The number of patients diagnosed with diabetes under 50 has increased over the years. Therefore, early ABI testing is necessary to identify PAD and prevent disease progression. So the project aims to answer the PICO question. In adult patients with diabetes mellitus, does the implementation of ankle-brachial index improve screening and the identification of peripheral artery disease? After conducting the literature review, 25 articles were selected to guide this project. The articles were grouped into three themes. The first theme was diabetes mellitus and risk for PAD. It is uncommon for the patients, it is common for patients with diabetes to have a higher rate of PAD in the lower extremities. Several studies showed that when patients are undiagnosed and undertreated, delayed treatment can increase the risk for PAD. Patients with an uncontrolled hemoglobin A1C have the strongest association with PAD. The second theme is the early detection of PAD using the ABI. So when comparing other diagnostic tests, the ABI is a non-invasive, cost-effective screening to identify PAD that can be easily implemented in primary practice compared to other costly tests such as CT angiogram or magnetic resonance angiogram. The last theme is improving patient outcomes through early detection. Providers must provide patients with dietary and lifestyle education. However, when patients are diagnosed with PAD, it is critical that patients are started on medication and referred to a vascular specialist if necessary. Delayed diagnosis may increase the risk of cardiovascular events. Initiating medication and emphasizing strict adherence to treatment is integral to PAD management. The medication regimen will usually include statins, aspirin, and antiplatelet therapy, which is the guideline-directed medical therapy for patients with PAD. Early vascular referral may prevent vascular surgery and amputation. The literature critique included strengths, weaknesses, gaps, and limitations. The strengths across several studies showed that 16 had significantly large sample sizes. Large hospitals and multiple sites also increased generalizability for the chosen population. The sample participants of several studies provided diverse demographics such as age and ethnic groups, and various studies used were extensive randomized controlled trials demonstrating that the ABI is shown to be simple, non-invasive, cost-effective, and a powerful risk indicator to detect PAD. This also increased validity and reliability. The weakness of this literature review was the large number of cross-sectional and retrospective studies. The gaps in the literature were that the project targeted all adults over the age of 18. However, multiple research studies did not investigate patients under 50. Although the risk of developing PAD under 50 is rare, it still exists due to the increase in diabetes. With a significant increase in childhood and young adult type 2 diabetes, there is a greater need to test diabetic patients for PAD regardless of age and symptoms. The American Heart Association corroborates the statement, suggesting that all patients with type 2 diabetes and one risk factor for atherosclerosis under 50 are at a higher risk for PAD. Due to the significance of multiple patients' comorbidities and health conditions, the all-cause mortality rate, including patients dying from cardiovascular events before completing the study, was a limitation noted in some of the studies found in the literature review. The theoretical framework that is applicable to this project is Knowledge to Action, KTA, which is essentially moving knowledge into action. The action cycle addresses 7 concepts. 1. Identify, review, and select knowledge research relevant to the specific topic. 2. Adapt knowledge or research, local contacts. 3. Assess barriers to using knowledge. 4. Collect, tailor, and implement interventions. 5. Monitor knowledge use. 6. Evaluate outcome. And 7. Sustain knowledge use. In this project, identifying the need to implement ABI screening in patients with diabetes mellitus and create awareness among clinicians in primary clinics. Secondly, studies have been researched and synthesized on ABI and used in the project guidance. Lastly, current PAD symptom questionnaires and ABI practice guidelines were used on patients with diabetes mellitus. As the process continued, the action cycle was initiated by critically appraising the usefulness of the ABI. And as staff adapted to the knowledge change, usefulness, and appropriateness of the ABI tool in primary clinical setting, potential barriers with patients were addressed, which included patients opting out to proceed with ABI assessment. However, this was overcome with counseling and education. Additional barriers were staff not properly using the ABI, and this was overcome by additional training and oversight. As the process was implemented, the primary clinician monitored results, evaluated, and initiated intervention. As knowledge was gained, the primary aim of this DNP project was to make ABI screening in diabetic patients sustainable in primary care. The methods section of the project included participants who were adult patients 18 years and older who were seen at the primary clinic located in South Texas. These participants were diagnosed with diabetes mellitus and were male and female. 4 of the patients were white, 7 Hispanic, and 18 Black. Although patients were from diverse ethnic groups, the clinic's primary demographic was predominantly Black and Hispanic. The quantitative quality improvement project was conducted through a retrospective chart review between May 6 and June 30th that included nominal and ordinal data. Nominal data collected was categorized as the number of patients screened over an 8 to 10 week period. Ordinal data was used to group ABI measurements into categories starting from normal, acceptable, some arterial, moderate, and severe arterial disease. Data collection included reviewing for inclusion and exclusion criteria. A sample size of 29 patients was screened. A data collection sheet was created to record weekly ABI results and necessary interventions. Data analysis from the patient's EMR included ABI results for newly diagnosed, chronic, symptomatic, and asymptomatic patients with diabetes, IC symptoms, and the number of screenings weekly for 8 weeks. The materials used were IC questionnaire, ABI screening tool, ABI worksheet, and EMR system. Resources for the project included an ABI system, file cabinet, printer and supplies, travel expenses, and face masks. All patient identifiers were removed to minimize the risk of breach of confidentiality. The list was kept in a locked file cabinet and was accessible only by the student and clinic manager in the clinic manager's locked office. So the results of the project revealed that the ABI was effective for detecting various stages of PAD. For patients with an initial negative ABI, screening will take place annually. Patients were provided with lifestyle and dietary education. Patients with a positive ABI screening were recommended to start medication and referred to a vascular specialist. 100% of patients with mild PAD were started on medication and antiplatelet medications. 100% of patients with moderate PAD were referred to a vascular specialist, and 100% of patients with severe PAD were referred to a vascular specialist. The medical assistant and clinic provider were the facilitators during implementation. Barriers to the project were patients that did not want ABI screening. However, that was overcome by additional education and having them to read over the pamphlet that provided them with information about PAD. Unintended consequences were inclement weather and transportation issues, and this resulted in weekly fluctuations in ABI testing. The IC questionnaire revealed that 12 patients were symptomatic and 17 were asymptomatic. The ABI results showed 8 patients with ABI greater than 1.4 presenting with calcification in at least one extremity. No patients had an ABI of 0.8 to 0.9 showing some arterial disease. 6 patients had an acceptable range of ABI of 0.9 to 1. 3 patients showed 0.5 to 0.8 indicating moderate arterial disease. 2 patients with ABI less than 0.5 showing severe arterial disease, and 10 patients with a normal ABI of 1 to 1.4. There was a difference in weekly ABI screenings. In week 1, 7% of patients were screened. In week 2, ABI screenings increased to 17%. In week 3, ABI screening decreased to 10%. There was an increase in week 4 to 14%. In week 5, 7%. Week 6, 10%. Week 7, 21%. And week 8, 14%. ABI screening showed that 2 patients were screened in week 1. One patient had a normal ABI range and one had an acceptable range. Week 2 shows 5 patients, 1 with calcification, 3 normal, and 1 with some severe arterial disease. Week 3 were 3 patients, 1 with calcification, 1 with acceptable, and 1 with moderate disease. Week 4 had 4 patients, 1 calcification, 1 normal, and 2 acceptable. In week 5, 2 were with calcification. Week 6 had 3 patients, 1 calcification, 1 normal, and 1 moderate arterial disease. And there were 6 patients in week 7, 1 calcification and 1 normal, 2 acceptable, 1 with moderate disease, and 1 with severe arterial disease. And lastly, week 8 had 3 patients, 1 with calcification and 3 with a normal range. So after ABI screening was completed, all 29 patients were provided with nutritional education. 19 were provided with a PAD informational pamphlet. PAD was detected in 13 patients. One of these patients was asymptomatic. The patients were started on medication and referred to a vascular specialist for further disease management. Patients with an ABI of 1 to 1.4 normal were provided with nutritional education, and 0.9 to 1 acceptable were provided with education and a PAD informational pamphlet. This project aimed to detect and mitigate the progression of PAD by utilizing ABI screening in patients with diabetes. The results of this project answered the PICO question: in adult patients with diabetes mellitus, does the implementation of ankle-brachial index improve screening and the identification of peripheral artery disease? Compared to previous studies, the findings were consistent with current research by demonstrating that ABI screening is effective in detecting PAD and that early intervention is imperative to prevent the progression of the disease. The project outcome was consistent with the strength of the previous data and supported evidence that PAD is more common in patients with diabetes. These patients can benefit from ABI screening during primary clinic visits to mitigate PAD progression. Also identify cardiovascular risk and prompt diabetes management. Out of the 29 patients screened in this project, 13 were found to have PAD. Subsequently, the patients were able to get immediate intervention. Multiple studies have also shown that ABI testing in patients with diabetes is vital and reduces the risk and progression of micro and macrovascular disease that may lead to an increase in morbidity and mortality. Implications for this project gives insight into how to address caring for patients with diabetes and screening for PAD utilizing the ABI. There are many reasons for integrating ABI screening in primary practice to detect PAD in patients with diabetes. Patients with diabetes have a greater risk for major cardiovascular and major limb events such as stroke, heart attack, and lower extremity amputations. The ABI is a standard, low-cost, non-invasive test that can be used to detect PAD. Incorporating ABI screening can improve primary care practice. Providers play a key role in educating patients on recognizing signs and symptoms of intermittent claudication, the importance of diabetic foot care, empowering them to take an active role in their health. Some limitations that may have affected the results of the project was that there was an expected weekly increase um, in screening. However, due to uncontrolled circumstances, there were fluctuations in week-to-week screenings, resulting in a smaller sample size as discussed previously. In addition, the small sample size of this project could have been attributed to the lack of identification of asymptomatic patients. Though the purpose of this project focused on patients with diabetes, the project did not expand on patients with other health conditions that increase the risk for PAD. In addition, the time frame in which the project was conducted prevented the DNP student from being able to assess a larger population. Performing ABI screening on a larger sample size may have enabled detection in asymptomatic patients. The project highlights future research needs, including conducting more extensive studies on screening and the risk associated with asymptomatic patients. Clinicians easily disregard asymptomatic patients with diabetes and do not screen them for PAD. Research showed that PAD was found in asymptomatic patients with diabetes using ABI screening. And early screening in patients with diabetes is highly recommended regardless of symptoms. In conclusion, the recommendations are to implement ABI screening in primary care setting and to use a multidisciplinary approach by collaborating with endocrinology, podiatry, and cardiology teams to optimize patient care. In addition, comparing pre-intervention ABI scores to post-intervention ABI scores is an approach to improving the outcomes in this population. The sustainability of this scholarly project can be evidenced by the project's outcomes in detecting PAD in patients with diabetes using the ABI, which is, again, a low-cost, non-invasive, easy-to-use screening tool. Expanding ABI screening to patients who smoke and have uncontrolled hypertension and hyperlipidemia will be beneficial as these patients also have an increased risk for PAD. Expanding screening to mobile clinics, community health centers, and skilled and long-term facilities will benefit a wide range of individuals who may need access to a primary care physician. Creating PAD awareness campaigns, community outreach, and advocacy programs are vital. Contact state legislators to encourage the establishment of a policy on making screening for PAD mandatory. And lastly, providing educational materials such as brochures and workshops in rural and undeserved communities is essential in creating and maintaining awareness. The goal would be to standardize ABI screening in primary clinics for patients with diabetes by working closely with stakeholders. Here are the references for your review. Thank you for watching, and I hope you enjoyed this presentation.